talking a little bit today, every time I say the value, potential value of this questionnaire is something like prognosis, treatment planning, evaluation, discharge planning. I keep saying this thing about prognosis, and I want to just talk a little bit about it. I will say that this is probably the area that I do the most work in, personally, is in prognosis. And really, it's a funny field, of course, because I'm trying to predict the future. You know, it's the art of creating a better crystal ball. And so I want to provide to you just a couple of things, and again, this isn't a massive module here, but just a couple of things that I've learned over the years of working in this field that might help you as part of your assessment for patients in pain is looking at the prognostic side. We'll start with another one of these poll everywhere questions, if you wish. Okay. Considering consistency and predictability. Okay, so you're considering these two things. So how consistent these predictors are and how much they're able to predict outcome. What is the strongest predictor of chronic pain 6 months after acute whiplash? We've got female sex, age over 55, high NDI score, numeric rating scale pain intensity of greater than or equal to 6, and a pain catastrophizing score. So, the point of this question, first of all, if you look, I'm asking predictor of chronic pain, not chronic disability, not chronic, work absence. And so, as I was mentioning earlier, the best way to predict an outcome is to ask the same question at baseline. And so in this case, the numeric rating scale, certainly in whiplash, we've done a couple of meta-analyses now, and both times, pain intensity on the numeric rating scale, 6 out of 10 or higher, has been the most consistent predictor of chronic pain 6 months later. Had I said chronic disability, then one of those, perhaps NDI score might have been different. Now that said, every one of these does show up there. So age over 55, female sex, high NDI score, high pain intensity, and pain catastrophizing score all show up there. One comment as we get going here talking about prognosis is that I believe that estimating risk is useless if you don't have anything to do about it. As of right now, I'm not really sure what to do about people being female or people being old. Older, not so. Elevated age. So those things normally don't factor into my own personal risk assessment. Excuse me. Because there's really nothing for me to do about it. I'm more interested in maybe some of these other things down here and some of the other assessments that we've done today. So what I hope we're going to do, this one shouldn't be too long, it'll take about a half hour. Understand the concept of prognosis or risk-based assessment, which I think is particularly valuable, and identify consistent risk factors of chronic problems in neck and low back pain. If we look at the course of neck and low back pain, generally we can say that, and you probably recognize this, the majority of recovery occurs within the first 6 weeks. Our current estimates right now of developing chronic pain following a traumatic injury is actually fairly high. Somewhere between, say, 30 to 50% of people with whiplash injuries and 20 or 30% of people with low back injuries, which is pretty high when you think about it. And in fact, unfortunately, as of right now, there's not a whole lot of evidence to suggest that we can really affect that direction. In fact, a couple of big randomized trials that have recently been published in the Lancet, of all places, have suggested that early rehab is really not that effective for whiplash injuries, which is a bit problematic, I would have to think. And in fact, that started to trickle its way into policy decisions. My understanding, I believe, specifically in the UK right now, there's some discussion around sort of really whether there's any value in, say, early physio or something like that following a whiplash injury, and that may get removed from funding models. So a bit of a problem here. And yet it continues to happen a lot. And so basically what's happening is that these randomized trials are saying, we randomize people into two or three groups. We either treat them in an active way or we give them a single session of advice and education. We follow up after 3 months or 6 months, and there's really no difference between the two groups. The result of that is folks say, well, then I guess we're best to just give people a single session of advice or education because it's cheaper. I have to think that we can do better than, well, stay the course, 30 to 50% of you are going to get worse and just become chronic anyway. Surely there's something better we can do. I think, in my mind, there's some value in this idea of prognostic subgrouping, identifying prognostic risk factors. If we take that example, if we just take everybody who's had a whiplash injury and we randomize them to this group or that group, if let's say half of both of those groups are going to get better regardless of what we do, sometimes despite what we do, then it shouldn't really be much of a surprise that overall the mean differences aren't that exciting. Okay? My belief, and I'm just going on beliefs now, I have nothing to back this up with yet, would be if we were to somehow be able to identify, reliably identify those people who are at risk of a long-term problem, so at risk of chronic problems, and only randomize them to our fancy intervention or our single session of advice, we'd probably see a difference there. So I do think that this idea of prognosis actually is somewhat important for sort of our own professional survival here, because otherwise we're going to keep getting these sort of large trials. And again, this is not meant to be a knock against these trials. In fact, I know the people who have done these trials, I think they're very good, high-quality trials. I mean, they're published in the Lancet. Those are good trials, no question about it. But in my mind, it highlights the importance of being able to identify who's actually going to go on to develop long-term problems and who's not. And let's let those who aren't just be. Let's let nature take its course. Let's not try to intervene. Let's try to intervene in those who actually do have a risk of a problem. On the flip side of that is this idea that if there is very little risk, then why bother intervening? Let nature take its course. Intervening in those cases actually runs the risk of developing an iatrogenic disability, where people think like, oh, without treatment I'm not going to get better. In fact, sometimes that becomes a self-fulfilling prophecy itself. So there's nothing wrong with just letting, some people saying, you had a car accident, yeah, your neck's sore, your neck's a bit stiff. I'm not seeing anything that's really causing me any concerns around the likelihood that you're going to get better, that you're going to recover. Keep yourself mobile. Maybe not the best time to take up a brand new exercise program or anything like this, but keep doing your everyday activities. I'll call you next week to make sure things are getting better. And pretty well let them go. So I think there's two sides of this coin. For one, we want to be able to identify those who would benefit from multimodal care early on. On the other hand, we want to be able to identify those people who we probably should just keep our hands off of and let nature take its course.